and we will upload the recording and the webinar slides to our website in the coming days. All right, Sarah Thibodeau says her favorite Black author is N.K. Jemisin. Awesome, thank you, Sarah. Callie just read the book Black Cake, and it's phenomenal. I love when books are turned into shows. The Fire Next Time by James Baldwin from Karen. Lauren J. Turner creates beautiful, diverse, and representative lactation paintings. That's awesome, Tasha. Thank you. For anyone who is just joining, please type your name and institution into the chat, and optional, share your favorite book, art piece, movie, show by a Black creator in celebration of Black History Month. Karen loves Black Cake. Bonnie Glass loves The Color Purple, which is also being turned into a movie. That preview looked really good. All right, Audra, I think we can get started whenever you're ready.
Yeah, great. Go to the next slide. So we're really excited to have everybody today. We're going to have a team presentation from Mercy Medical Center to talk about the work that they're doing to address maternal equity. Go to the next slide, and then we'll have a Q&A after. As always, I want to thank the PNQIN Maternal Equity Bundle Work Group. Many faces here that you see just indicates just how many people have contributed to the work that you see moving forward with PNQIN. And every bundle that we're engaged in will tend to continue to look at maternal equity and look at those issues related to those who might have differences in outcomes based on race, geography, language, and ensuring that we're moving in the right direction to ensure that all moms have an equal opportunity to have a great birth outcome and a great birth experience. All right, next slide.
Trying. There we go.
So we've got a good number of hospitals that have engaged with the birth equity work, about 22 hospitals. As you can see, a good spread across most of Massachusetts, a little less over in the western part, but we've got Springfield and as far west of Springfield engaged in the work that we're doing. And go to the next slide. And we have a couple of reminders and announcements, and just want to also say that I'm really excited that we're in year 2 of this equity bundle with hospital teams presenting on the work that they're doing, so that we can continue to share, drop the walls of the silos, and continue to share with each other what's happening in our spaces so that we can improve upon the work that we're doing. All right, I'll send it back over to you, Callie.
Thank you, Dr. Meadows. So first, a quick announcement about the remaining Equity Bundle webinars. We're so excited to share that all of our upcoming presentation dates have been filled with a presentation from a hospital team. So huge thanks to Mount Auburn for volunteering for April, which was the one we had left. So today we can look forward to hearing from Mercy, and then next month from Martha's Vineyard, and then throughout the rest of the spring and summer, Mount Auburn, Lowell General, and Tufts. So thank you so much to all these teams for volunteering. And for our next announcement, I'm going to invite Dr. Kristen Price, PNQIN's Administrative Director, to share about an opportunity around remote blood pressure monitoring.
Thank you, Callie. So for some of you may know, we received a 5-year HRSA grant, and part of that funding is supporting postpartum remote blood pressure monitoring programs at 2 hospitals, at the Brigham and Women's Hospital and at Bay State, both of which have been extremely successful. We're starting to get some prelim data and patient feedback, and it's all been incredibly valuable. Remote blood pressure monitoring has also been identified as one of the top priorities for the state, coming down from the governor and the secretary and the DPH commissioner. And so the Health Policy Commission reached out to PNQIN because they are interested in an investment opportunity to help support other hospitals across the state launch their own remote blood pressure monitoring programs. And so Health Policy Commission just was asking if PNQIN could kind of get a sense of if there was funding opportunity to be able to start a program like this not just the funding, but with technical assistance and coaching based on the success of the pilot. Which of your hospitals would be interested in applying? This does not commit you to anything, but just to kind of get a sense of how many hospitals across the state would be interested if there was funding as well as technical support and collaborative learning around launching a program like this, with the ultimate goal that Mass Health will eventually reimburse a program like this, but until we can get that full reimbursement, being able to support hospitals to do this. And people can reach out to Callie or myself if they have any questions. More to come on this. Thanks, Callie.
Yeah, thank you, Kristen. So far, the results of the poll, several folks would be very interested or somewhat interested in this opportunity. A few would like more information, and that's totally fair. We can supply that. But this is really helpful for us to know. I'll just give a few more seconds on the poll, and then we'll get back to our other announcements. But if you missed the poll, feel free to shoot me an email to let me know that you're interested or would like more information. Awesome. Thanks, everybody. So yeah, we've got lots of interest, which is wonderful. Thanks all. All right. Oh, stop sharing. There we go. Okay. Moving on to some of our other announcements, just a reminder that the equity bundle in its current version will be running through until the PNQIN Spring Summit on June 26th of this year. And then components from the equity bundle will carry over into our next bundle implementation, which is the perinatal mental health conditions bundle. We're looking to start implementation of that in the fall in September, with onboarding to begin in July. So if anyone already knows they're interested in that bundle, feel free to shoot me an email. Speaking of summits, just also another reminder that all of our materials, slides, presentations, and resources from our most recent summit in December are available on our website. And Caroline is posting links to these resources and the ones I'll talk about in a moment in the chat. PNQIN is excited to announce that we have opened our nomination period for PNQIN Awards. I sent an email out to folks last week on the 14th with guidelines for each award category and instructions for submitting nominations. We'll have this period open until mid-March, and the winners will be honored with a ceremony at the PNQIN Summit in June. So we're really excited to collect your nominations. You can read more about what each award is for in the email that I sent, but I do want to point out that the Hospital Team Award will be giving out 2 this year, recognizing 1 tertiary care center and 1 community hospital. So we're really excited to acknowledge all the hard work that teams and individuals across the state have been doing. So this is no longer an upcoming webinar, but just wanted to plug that the recording for this webinar from the Institute for Perinatal Quality Improvement, where our very own Dr. Audra Meadows was the speaker, is now available to watch for free on PQI's website, and was a really wonderful description and discussion of the role of PQCs like PNQIN are successful in achieving birth equity across the country. Also want to plug that PQI's anti-racism challenge for the month of February is still going on. I know it's February 20th, but it's never too late to join if you'd like to receive the last 9 or so days of daily email prompts to each day's challenge activities. So you can sign up in the link that Caroline's putting in the chat. Also coming up from PQI, there is a Massachusetts Speak Up Champion training coming up in March, on March 15th and 22nd. This is a virtual training. It's completely free thanks to support from Massachusetts DPH. We ask that you please register by February 23rd, so the end of this week, if you can, just to ensure that you get your workbook for the conference on time. If you have any questions about the training, feel free to reach out to us. And for those who are already champions, but looking to take the next step with their Speak Up education, there will be a Speak Up Ambassadors course on May 17th. This is just to deepen your Speak Up education and further learn and create plans for implementing strategies to increase equity and reduce health disparities. And if you'd like to take Speak Up a step further, you can apply to be a Speak Up faculty member, which means you would be trained to host and deliver Speak Up trainings at your own institution. So the deadline to apply to become faculty is June 1st. Also from PQI, they are hosting a lottery for their upcoming birth equity web-based modules. If you complete the form below by March 15th, you'll be entered into the lottery to win free access to these 4 modules. By completing the modules, you'll learn how to write an anti-racism statement, how to improve data collection, perform debriefs using a racial equity lens, and ensuring maternal care standards are met for birth equity. So this is a really great opportunity to receive a wonderful resource for free. And also just want to note that these modules are based on this series of webinars that PNQIN and PQI collaborated on in 2022 around the same topics. And these are available to watch for free on the PQI website. Few slides left before I turn it over to the Mercy team. A couple announcements from our partners at March of Dimes. The March for Change Advocacy Day is coming up on March 28th. You will meet with March of Dimes leaders at the Omni Parker House Hotel in Boston before walking over to the State House to meet with lawmakers and advocate for topics that mean a lot to you. So this is a great opportunity to network and connect. And then the March of Dimes March for Babies event in Boston will be on May 11th on the Esplanade. You can register a team and fundraise. I know A1 has a team. I don't know if Karen Manganero or Mimi Pomelo are here and able to provide the link to join their team, but that's a possibility, or you can create your own team. Lastly, we have an invitation for those at baby-friendly hospitals. There is a study team at Boston Medical Center who is conducting interviews with baby-friendly staff and supervisors about their experiences and any recommendations they may have for implementing baby-friendly. So if you're interested in participating, you just need to complete this very brief 5-question survey to ensure your eligibility, and then the study team will reach out to schedule an interview at your convenience. And all participants will be given a $50 gift card. So as always, PNQIN has several resources available for bundles and maternal health care best practices available on our website. These are just a couple that we've created. And with that, I will turn it over to the Mercy team. Thank you both so much for being here.
Okay, you can go to the next slide, please.
Okay, thanks a lot.
So this is our introduction slide. So we are Mercy Medical Center. We are a small community hospital out of Springfield, Mass, right in Western Massachusetts. We are part of a regional hospital with Trinity Health of New England. Our name is the Family Life Center. We are a very small labor and delivery unit. We have about 6 labor rooms, 10 postpartum rooms. We do have about 800 births a year. Our patient population is 55% non-Hispanic white, 20% Hispanic white, 12 non-Hispanic Black, 7% Hispanic Black, and about 5 other. Me and Callie, I'm the nurse manager here on the unit, and Callie is our nurse educator.
Hello.
Next, please. So I have to be honest that I just stepped into this role in August as a nurse manager. And when I had been working in the equity bundle in my previous position. When I first entered the equity bundle, we really didn't have an idea about how to start this work. We knew that we needed to address disparities in maternity care, and it was something that was important to us. But how we were going to go about doing that work was kind of like, we just didn't know how to get started. So when the invitation to join the equity bundle was presented to us, we thought it was a great opportunity to kind of get our feet wet and get this project going with some support and guidance from PNQIN. So we started with just using the structure measures as our guide to get the project started. Next slide. So Callie's actually going to take this. I almost took over. So Callie.
Hi, I'm Callie. I work with Laura as I'm the nurse educator here at the Family Life Center. So going right into the structure measures that we kind of use, like she said, we didn't really have any idea what we were doing. So all this information in the toolkit was super helpful for us. So starting off with the first structure measure here, does your hospital have a formal equity team based in obstetrics or reproductive health that includes diversity of roles, race, ethnicity, and community member representation? So we did not have an equity team specific to our unit when we first joined this equity bundle with PNQIN. So one of our first steps was to create this team. I kind of took that on as my baby. Laura does the quality team and many other things. I kind of took on this equity team. So how did we go about creating this team? So we decided to educate our staff on the meaning of healthcare equity first. Why is it important? What is it? And how it is so crucial to improving maternal and neonatal outcomes. We then recruited multidisciplinary staff to join the team. So we did that by shooting out a unit-wide email inviting people. And then also there were a few staff members that came to mind of people that might be interested in this work that we went to individually. We were able to recruit registered nurses, assistant nurse managers. We have a certified nurse midwife. We have an anesthesia medical doctor, and we have an IBCLC on our team. So we have a pretty good scope of roles within our team. We also wanted that important aspect of the community member representation as well. So Laura had the great idea to reach out to our local WIC office. So we reached out to them, and their program director was actually super happy to join this team with us. So she is on the team. And then I also had a past patient kind of pop to mind. She had given birth with us twice in the last few years. After she gave birth here, she had friended me on Facebook, and I felt like we kind of had that relationship where I could ask her if she might be interested in something like this. And she was so excited to join the team. So she is on our equity team as well. So we were able to hold our first quarterly equity meeting. We are planning to meet quarterly, every 3 months or so. We did share the recording of the meeting with our entire staff so that everyone, not just the equity team, could listen up and see what was going on. During this initial meeting, I really worked on educating what is healthcare equity, why is it important, and educated the team more about basically what we're telling you guys today, this initiative that we have implemented on our unit, and why we're doing it. I think that helps the staff be on board when they understand that this work, it really makes a difference and it's so important. At this meeting, we also discussed, at this meeting, we also discussed how best to implement OB-specific equity training onto our unit. And one of the ideas that got thrown around was to add it into our RN orientation program. So I've actually done the Speak Up Champion training, and I'm signed up for the ambassador training in May. And I just took a picture of your screen about the faculty because I would love to be able to teach that here to our team as well. Next slide, please. So moving on to the second structure measure. Kaylee, could you switch the slide for me, please? Sorry. It doesn't want to work today.
So sorry. Yeah, let me.
Okay.
Okay. Do you see number 2?
I don't.
Oh my goodness. I'm so sorry, everybody.
It's
Let
fine.
me
I'll take
try.
the opportunity to get a sip of water.
Perfect timing.
Try resharing.
Mm. There we go.
Okay, excellent. Thank you, Kaylee.
Sorry about that.
So moving on to the second structure measure, has your hospital developed and communicated their obstetric equity goals to the perinatal faculty and staff, including SMART or AIM equity goals, an anti-racism statement, or change statements? Um, so we had partially had this structure in place. So we did do QI projects and we did communicate that to staff via our ACE boards. However, it wasn't a very direct education regarding that. So we did, after joining this bundle, we are taking a more active approach and including the staff in that. Laura has her quality team that we've asked staff to join so they can be a part of those initiatives. And we do make sure to send emails, add to our updates and reminders, and discuss at our huddles any kind of initiatives that we are implementing. We also wanted to develop an equity statement. Again, we are part of Trinity Health of New England. So as a larger organization, they did have a very broad equity and inclusion statement. But we wanted to make sure we had one specifically in OB. As we know, there's such a huge disparity in OB specifically. We found that to be very important. So that was kind of daunting. How would we go about making such a statement and make sure that it's very inclusive and it gets the point across that we want? So Laura and I first started by researching equity statements created by other maternity units. And we kind of used those as inspiration, read quite a few of those. And then using those as a guide, we created our own. But we asked for input from many different members of the team, the equity team, Laura as the manager, myself as the educator, our medical director, our pediatric director, and our upper hospital leadership. And we were able to develop a statement that I'll read to you shortly. And we are working on getting that posted to our official website and also posted on the unit. Next slide, please. So this is the equity statement we developed specifically for the Family Life Center. So the Family Life Center at Mercy Medical Center recognizes that systemic inequities result in disparities such as poor obstetric and neonatal outcomes. Some of these outcomes include higher rates of preterm birth, low birth weight, maternal and neonatal morbidity and mortality. Individuals, families, and communities experience discrimination and systemic oppression based on race, ethnicity, economic status, education level, ability, religion, age, sexual orientation, gender expression, language, citizenship status, and many other identities. We embrace our responsibility to all of these patients and their families by participating in the ongoing work of creating an inclusive environment where all feel represented, supported, and safe. We strive to deliver care to all families in a way that is culturally affirming and respectful. We demonstrate these commitments by providing anti-discrimination training for all staff at the Family Life Center and committing to the ongoing and lifelong work of dismantling racism and other systemic forms of oppression. We solidify our commitment through relevant non-discrimination and harassment policies and inclusive protocols. Next slide, please. So now that we had our team and our statement, we moved on to the third structure measure, which asks, does your hospital collect race, ethnicity, and language data upon registration to the obstetric unit, and is it collected through self-reports? We were already doing that, luckily, so our unit was collecting this data upon registration through patient self-report when the patients arrived to be admitted or registered for triage. Number 4 asks if our hospital stratified process and outcome data by race, ethnicity, and language. So at the time, we didn't stratify data based on demographics in real time. So we did provide data to CHIA, the Center for Health Information and Analytics. They stratified the data for us, and then it was resulted to us at our annual SMM meetings. But again, those are once a year, so we were sometimes waiting up to a year to get this data. We wanted it in more real time. And then next slide, please. So the fifth and final step of the structure measures, has your hospital adapted and implemented a patient-reported experience measure? So before this, we had utilized HCAP survey results, and we had written our own unit patient survey just to see how the patient's experiences was, what could we do better. But after joining this PNQIN Equity Bundle, we did decide to implement the Team Birth Initiative. And I am going to take a little bit of time to talk about this because it does impact our equity. And it was also like the first big initiative that Laura and I kind of started on our own. As she said, we were both fairly new to the role. We had a big change in management. So this was kind of like our first little baby before we move on to into our big, like our, not big, but our equity project we're going to talk to you about today. So Team Birth is a collaboration between Brigham Women's and the Harvard School for Public Health. And that collaboration is called Ariadne Labs. So we were able to luckily join this team and they provided us support. And the project was implemented on our unit with the goal to empower, and this is a quote from their website, to empower all members of the care team, including the patient themselves, to play an active role in decision making and to improve safety and quality of care. So upon implementing this Team Birth Initiative, we did utilize a survey for patients to complete prior to discharge to capture their experience. So this was a PREM measure that we had utilized after starting this equity bundle. Next slide, please. So I'm going to talk a little bit about our implementation of the Team Birth Initiative. And so first off, to prepare for this launch, Laura and I did attend monthly meetings with Ariadne Labs to learn more about Team Birth and how to launch such an initiative. We educated our staff regarding the Team Birth process and the purpose of Team Birth and why we wanted to implement it in the first place, what benefits we foresaw. We consulted multidisciplinary teams, such as our medical director, pediatric director, anesthesia, because we needed everyone to be on board. And then our final step before implementing this was we did design and purchase new whiteboards for all the patient rooms. We made sure that these whiteboards included a list of the team members, and the patient is actually the number one member of the team. And that's just, again, to show the patient that really they are the end all be all in these medical decisions. We can give them our opinion, but ultimately it is their decision. They have control of their care. Also with this Team Birth Initiative, one of the most important things are these huddles, these multidisciplinary huddles that occur at the bedside with the patient. So utilizing these whiteboards upon admission and then every few hours throughout their stay in the hospital, or anytime a big event comes up, like they decide to get an epidural, their water breaks, maybe the baby's acting up on the monitor, and we have maybe a little thought in our head that a C-section might be in their future. We don't want the patient to be blindsided by these things. So we have these multidisciplinary huddles at the bedside so that the patient is kind of included in that team collaborative conversation. They can ask questions, we can ask questions, and make sure that everybody's on the same page. And then the patient feels like they truly are a part of that team. Next slide. So from these PREM measures, the post surveys that we provided to the patients in their discharge packets, we were able to get a lot of data. And I do believe that these surveys were provided by Ariadne Labs, correct, Laura? Yes, they provided those for us.
That is correct.
They had a lot of questions. I think it was about 13. I'm not going to make you go through all of those, but I do want you to take a peek closer at this chart on the left side here. It does have a few questions, and I want to focus on number one. I could take part in decisions about my care. So I'm just going to explain this chart a little bit. So in the blue, we have our non-Hispanic white patients. In orange, we have our non-Hispanic Black. And in green, we have our Hispanic population. And this is Mercy specific data. So this is our specific unit implementation of this program. So the light colored bars are going to show you the patients that did not or weren't sure whether they had teen birth huddles. And then the darker bar shows the patients that did have teen birth huddles. So for number one, 67% of patients that did not recall having teen birth huddles said they strongly agreed with the statement, I could take part in decisions about my care. Whereas if you look at the dark bar, 80% of patients that did have huddles strongly agreed with that statement. So that's a really big increase of 13%. Just by having those huddles at the bedside, the patient felt that much more likely that, or much more that they were able to take part in their care. And of all the questions, every single one went up with the huddles, except we did have one question that stayed exactly the same. So that was really, really nice to have that data, to be able to support this project initiative and to be able to share it with the staff, that it really is making a difference. So now I am going to let Laura discuss our hypertension equity project. Thank you.
So I'm sure all of you are kind of in the same boat, where we have been noticing that we've been having an increase in the patients that we see that are diagnosed with gestational hypertension in preeclampsia and pregnancy. And we did a little bit of research, and we learned that patients who have gestational hypertension in preeclampsia and pregnancy are an increased risk for poor cardiac outcomes within 10 to 15 years of their pregnancy. So we thought this would be an important work to start doing and trying to improve these outcomes. So we also knew that people of color are more likely to suffer from hypertension due to factors related to food insecurity, economic status, healthcare access, or just regular disparities. So we decided that our project goal would be to improve primary care provider follow-up within 6 months of delivery for Trinity Health patients with gestational hypertension and preeclampsia. So we kind of started kind of small and targeted that group. So in July of 2023, after working through the workflow a little bit, we decided to launch our project. What did the preparation to the workflow look like? Well, we started with creating a driver diagram, which again is one of the things that it was encouraged to us to do by the PNQIN equity bundle. So we kind of just started, okay, what is our goal? And try to identify what are going to be our key drivers to make sure we get towards that goal. And one of them obviously was to make sure that we were identifying the gestational hypertensives and preeclamptic patients that came to our unit. We also knew that we needed to provide education to the patients so that they knew that they needed to follow up with their primary care provider, because maybe they just didn't have that information. And then we also wanted to make sure that we communicated with the primary care provider team they also might not know that these patients were at increased risk for poor cardiac outcomes, and we needed to they needed to be seen. So I think one more, Callie, I'm sorry, that one. Okay, sorry about that. So from then, after identifying the drivers, we kind of decided what ideas did we have to try to address those to get us to that end goal. So the first one was we requested a report be built that gave us the data back as to how many gestational hypertensives or preeclamptic patients we had that had a Trinity Healthcare primary care provider, to help us track how our interventions were doing, like whether they were successful or not. We also stratified the data based on race and ethnicity, and we obtained education for patient distribution. And originally, I have to say, we started with just English, and then we realized that it's kind of like one of Joint Commission requirements is that we provide education in our primary patient population languages, and for us that's Spanish and English. So we did go back and get that education in Spanish as well. And then the other step was trying to make how do we identify the patients for the primary care providers, so the primary care providers knew that they had to follow up with these patients. So we worked out a workflow in providing the discharge summaries to the primary care providers so that they knew that these were patients that were identified as needing follow-up. And then this last one here, facilitating appointment and scheduling prior to discharge, that one came a little later when we were realizing that we weren't quite hitting the metrics that we wanted. So next slide, please. Thank you. So again, we just built, their drivers were to build a report, to collaborate with the outpatient offices, and to educate our staff. Next one. I'm a little ahead. Okay. So prior to implementing the project, we kind of just started with analyzing our data, like our pre-implementation data. So we ran a report from August 22 to June 2023, and we noted that the follow-up rate for patients with preeclampsia and gestational hypertension that had Trinity Healthcare primary care providers was 35%. We were able to stratify that data based on language, race, and ethnicity, and we noted that there was a lower follow-up rate with our BIPOC and Hispanic patients. So our white, non-Hispanic white rate was 40.9 versus our BIPOC and Hispanic patient rate was 31.6, which gave us a difference of 9.3% for between those two patient populations. Next slide, please. Okay. So again, like I said, additional steps, we were able to obtain those materials, educational materials to the patients in Spanish. We also created a nursing postpartum checklist to improve follow-up and compliance with patient education. And we also completed we developed an audit tool for the A&M team. And that kind of had a couple of, there was a couple of reasons as to why we implemented that one. One of them is just to double check on the nursing team and make sure that, you know, there were no fallouts there, but it also helped us to follow up with the patients after they were discharged from home, discharged from the hospital to follow up at home. We collaborated with the Trinity Healthcare primary care provider offices, schedule appointments prior to discharge from Family Life Center. So when we first started the project, we were doing this, and we were leaving it up to the patients to schedule it. And you know, it gets hectic once you bring a baby home. There's a million demands on you. You're tired and all these things. So we decided we would try to schedule the discharge appointments before they left the hospital, so they would be one less thing they had to worry about. We also asked for a meeting with PNQIN to make sure that we identify any areas of potential improvement within our project, and kind of just to make sure that we were on the right track. Next slide, please. So after doing our, so every month I actually review the data for the month before and kind of keep track of where we are at. So since implementation, our total follow-up rate between July of 2023 and present is 37%. We are a higher rate than our previous average, and some of our patients are still within our 6-month window. And I'll talk about that in the next slide a little bit. I'll make it a little clearer. The follow-up rates with non-Hispanic white is 41.2%, and our BIPOC and Hispanic patients is 34.5% with a difference of 6.7. The kind of one of the glitches to the project is that we do not see the results of our interventions with all our interventions that we do with our patients until the patient hits their 6-month mark, because they have 6 months in order to follow up with their primary care provider. So there's kind of a little bit of a delay that we see. But however, we are seeing that the patients are following up sooner than when we started the project. So they're at that 2-month, 3-month mark after their baby is born, they're already being seen by their primary care provider, which is nice to see. Next slide, please. Okay, so again, this is just kind of speaking to what I just mentioned. So as you see, as July of 25, our follow-up rate was of patients that were delivered in July of this year. Our follow-up rate was 25%. I will talk about the barriers to the project a little bit, and that will kind of explain why that one is not as high as we had hoped it would be. But you can see August, September, and October, the follow-up rate is already in the over 40%, and patients still have some months to go before they hit their 6-month mark. Next slide, please. And so this slide is just showing you before and after project implementation comparison between your non-Hispanic white and your BIPOC and the overall. And you can see that there is a little bit of, like, you can see the difference in between the follow-up rate for each group. Next slide, please. And this one is just a comparison by racial disparity, which is just showing us like the decrease in the disparity that we are noting. Next slide. So I'm sure like we are not the only ones that have barriers when we try to implement these projects. I have to say one barrier that we didn't list here is the fact that we are a very small community hospital, so our resources are kind of limited. Callie and I wear many hats, and we kind of try to do as much work as possible. So making sure that we get team involvement and we get staff buy-in is really important for us in order to continue to do this, be able to do this work. Like Callie mentioned earlier, in July, we had some management changes. I was the educator / perinatal quality manager. And then Callie was one of our A&Ms. Our inpatient director left her position. I stepped into the manager role. She stepped into the educator role. So there was like a little shuffling of positions, which kind of just everybody stepping into the role and learning a new role. It kind of makes it difficult to keep everything on track. We also had some education barriers with the team where we, and I'm sure this is not only something that happens to us, but you try to educate your staff and there's a delay in getting a process going and having it acclimated into their workflow and to make sure that, everybody is doing what they're supposed to do. So we did have to send emails a couple of times, like Callie said, included in the updates and reminders, making sure we huddled with the staff. We created the checklist for the nursing team to make sure that, okay, did your patient, did you identify the patient properly? Are they going home with medications? And did we make sure that they filled their prescription? Did they schedule their prenatal, the follow-up appointment? Did they schedule their appointment with their primary care provider? All those things. Did the discharge summary go to the primary care provider? Those are all the things that kind of we included on the list. And then we also implemented the audit tool for the an A&M team. I have to say, we actually ended up adding a couple of things that after we initially implemented it. We decided that we wanted to identify whether they had a primary care provider or not, because we realized that we were only targeting the Trinity Health primary care provider patients. And so we were missing like half of the patients that had preeclampsia or gestational hypertension. So in the future, as we work to try to collaborate with other primary care providers, knowing who the provider was important. So part of that audit is to identify those primary care providers. And they also, our A&M team does a postpartum follow-up call with the patients 2 to 3 days after they get discharged. And during that phone call, they'll say, did you schedule your primary care appointment with your PCP if you hadn't done so while you were here? It's just as like an extra check-in. Data extraction actually is a little bit difficult. Again, I was doing it manually to start with, and that was a barrier. It took a lot of time, and we just needed some reports built to make it a little easier. We also have a very small sample size because we're a low birth volume facility, so we're only have 100 deliveries a year, and we kind of like pare down further because we were only targeting the Trinity Healthcare primary provider patients. So even though we potentially had, say, 15 hypertensive patients, and within 1 month's time, if only half of those had a Trinity Healthcare primary care provider follow-up with, then we were missing half of those patients. So we weren't seeing the true fruits of our labor because we weren't capitalizing on those other patients. And then again, like the collection of the follow-up data, which is collaborating with other primary care providers within the community to get whether those patients actually did follow up or not. And that is, next slide. So our hypertension project is still ongoing. We continue to monitor the follow-up of the patients that we have identified. We continue to review the data on a monthly basis, and we try to think of interventions to address any barriers or anything that's not working. And that's our project. Next slide. Thank you. And does anybody have any questions for us or any suggestions?
Thank you so much, Callie and Laura. That was fantastic. I'm looking in the chat to see if there are questions. And I'll just look across and see if there's any hand raised also. Thumbs up, last accolades, and reactions. You know, I have to say, I really appreciate all the work you guys have done. It's like you went from ground zero to having accomplished so much, which I think is just so laudable and takes a lot of concerted effort. I will actually say the way you guys presented it, it seemed like there was so much ease to getting it done. What do you think were some of the biggest challenges or some of the biggest facilitators? Do you feel like it was the fact that you have these roles, you know, that allowed you to get the work done? Or do you feel like there are other, you know, hidden factors that help really push the work forward?
I have to say, I'm pretty passionate about success. I feel like I have a good team where I can ask for things, and they do want to help, and they do want to make a difference. Even though, like I mentioned, like, you know, there's education barriers or whatever, the team is not, when you put it in the light where they understand why this work is important, everybody wants to improve the care that we deliver to our patients. They do have an understanding as to why it is important. And I think when you tap into that, when you make them understand like the difference that this makes, I think you get your staff buy-in, and then even with very small, limited resources, you can make it work.
Absolutely.
That is really terrific. I also just wanted to comment on your engagement with Team Birth. So many folks have talked about how it was a really great tool. We're really thrilled and excited that Team Birth agreed to partner with us with the Equity Bundle to be able to bring this work forward. And just to say a little bit about the PREM, it's a long story of an adaptation of a survey. But what's really nice is it's just a beautiful story of collaboration and how PQCs work together. The New York PQC, as well as the Illinois PQC, and then us have all worked together to continue to make small adaptations to this validated survey on respect and autonomy that was originally developed by Sarah Vedum in her birth lab in Canada. And from there, we were able to have this. And so it's really great to be able to see, not only see on our end, but also for you to be able to show patients just how many improvements you can see when we use the shared decision-making structure with Team Birth. I think that's fantastic that you were able to do that work and had so many people buy in. Was that a slow process, or was that a also one of the things where people just jumped right on bandwagon with Team Birth and moved forward?
Do you mean like the Team Birth?
Yeah. Do you feel like
Yeah.
the staff jumped on pretty nicely?
I feel like it did. I have to say, Ariadne Labs was absolutely amazing. It's kind of like a lot like PNQIN, where like the support that we got in order to launch the project was
huge.
outstanding. It was huge. It was at first when you look at the project, you're like, oh my gosh, this is so much, right? It's so big, and so many things to do, and everybody's already overwhelmed, and you know, everybody has a lot of things to do, right? We all have competing priorities, but when they kind of like break it down in chunks, and you're like, okay, by this time you need to do this, and then we had a meetings with a team, with the implementation team, and it's okay, guys, by this time we have to get this completed. And then sometimes we were like, you know, we were able to do the conversations within a meeting, but sometimes, okay, I would send an email out, and then they would give me feedback on the fly. Like, for instance, we first started with before we created the boards, we kind of just did a dry run on a piece of paper. And I said, okay, these are the kind of the things that how we're thinking it's going to look like. Go out there and use it and tell us how it's going. And then anything that needs tweaking, let us know. And so the nursing team went out there, tried it out, and then they brought it back in, and they're like, oh, I know, could we do this instead and that? So the fact that it was broken down in chunks and made manageable, and it actually like allowed the staff to kind of like slowly get integrated into it, because they were already kind of working through it as we were looking to implement it before go live.
Yeah, and I think it helped with the staff buy-in, because they felt like they were a part of it. They helped develop it. So then when they saw us actually buy the whiteboards with their suggestions, it helped them become more part of that too.
And we also included them in the education. So like, you know, the A&M team and the nursing team, they were, you know, they would get educated, and we would make them be part of the huddle. So you're the patient, and this is what you're going to say, and you're going to be the nurse. And this is what, you know, what would you do in this situation? How would you explain it to the patient? And so it got them really involved in it.
Yeah.
That's really true. There is one question in the chat that asks, did you find that there were any cultural differences between how culturally diverse patients perceived care that caused disparities in care? And if so, how did you overcome those issues?
That's a good question.
Yeah, that's a good question. We did know, I have to say that where I noted it is in the team birth data that we would get. It was always harder we wanted to understand why consistently we had lower scores for our Black patients. Consistently, they were always the lower score, even though we were trying to do, we were doing the huddles the same way. So I feel like, I'm not sure if that's, like just how they perceived the huddle, or maybe we were addressing. So that's actually one of our ongoing things that we try to look at. So even though the team birth project is really done for us, I still input the data and I still collect surveys just for information for ourselves to see where we stand and where we're at, and make sure we don't fall back or make sure that we improve going forward.
Yeah,
but we did notice that disparity, but I don't know how to overcome it. So I have to say.
I think part of that, like from my perspective and like the research I've done, is that, overall, unfortunately in our country and our healthcare system hasn't treated Black patients the same way. So I feel like sometimes the Black patients may come in already having a lower trust and not feeling as respected and as heard as some of our other patients do. So that's just something that tells us we have to do this work on our unit and continue what we're doing, but we also need to do this work in our everyday lives as well. So that way over time we can, shrink those gaps. But we're doing what we can on the unit, and it's discouraging, but it's encouraging in a way that like we can make a difference if we keep going with this.
Well, that's really terrific. What challenges do you see with sustainability, like being able to continue forward with either team birth and keeping the boards and keeping everybody engaged, or even with the Hypertension Project? Like, do you feel there's any challenges to continuing on? So
for team birth, I have to say, that's one of the things that we discussed in our last meeting for the team birth initiative, which was all the cohorts that went, all the hospitals that were involved in the cohort. How do we sustain it? And so making sure that we include this education in our orientation is one of them. I also discussed maybe giving the education again yearly to the staff, just as a reminder. The other thing, I just discussed this in our quality committee meeting that was yesterday, and we were thinking about doing audits for team birth huddle audits, and just making sure that they're occurring and what those are looking like. What are we discussing, and making sure that we are doing them the right way so that we are able to sustain the project going forward. For the Hypertension Project, I feel like we definitely have areas where I definitely think we should make to improve. One of them is just, again, making sure that we are collaborating with the primary care provider offices outside of Trinity Health providers. Just whatever primary care provider office in the community that we can collaborate with, just to make sure that those patients are getting followed up on, because it feels inadequate to me that I'm only really capturing like 49% of the patient population that we're trying to address. So I want to make sure that we get that follow-up. And we also, the other idea we thought, it was actually Callie's idea, to check in on the patients like 4 months after their delivery and say, hey, by the way, were you able to schedule that primary care appointment? If not, you should be really scheduling that within the next couple months as another added reminder. And then it gives us an opportunity just to check on the patient and say how you're doing. And then I also noted in the beginning of the presentation and the beginning of the meeting that, we have that potential to, participate in that blood pressure monitoring program, which is, could we implement that into this, and would that help us? Maybe if they see that, oh no, my pressure's still high, I really need to go back into the doctor's office and follow up. maybe that's something that can also improve us as well.
Yeah. One thing that I foresee getting easier, because it's very easy to see, I think, a lot of barriers, but like Laura said, we are working with a older charting system. We're still on Meditech. And so Laura is going in and manually extracting all that data, putting it in spreadsheets, calculating it, like, and a huge amount of work that she put into this. So once we are switching over to a more high-tech system where we can actually pull reports and create these like more in-depth reports without having to manually extract everything, I think that's going to make things a lot easier for us too. And we'll be able to look at more, not just race, ethnicity, and language, but other things as well.
Well, I just want to applaud everything you guys have done. I really liked your equity statement too. I wanted to say that and share that. That was really well written, and
Thank you.
really happy with all that you guys were able to accomplish. Thank you so much for your presentation. And I think a lot of people, you know, are listening and learning and probably taking some notes from how you guys move forward.
Thank you so much.
Thank you.
Yeah. Thank you, everybody. I'll turn it back over to you, Callie. Do we have announcements?
No, I think I went through all of my announcements previously, but just to go back to the ones that Laura and Callie both mentioned, please do reach out to me if your hospital is interested in that potential opportunity to receive support, excuse me, for remote blood pressure monitoring. We can give that information back to the Health Policy Commission. And also to speak up trainings still available as well throughout the rest of this year. And yeah, we look forward to seeing you all back a month from now, March 19th, where we'll have the team from Martha's Vineyard present about their equity work. So thank you so much to the Mercy team. That was incredible. I love your motivation and your dedication. We're so grateful that you both were here to present. And I hope everyone has a great rest of their school vacation week. Thanks for coming out.
Thank you, everybody.
Thank you.